Dr. Khalid will be talking about the current approaches in treating and management of aHUS. Dr. Khalid is a consultant nephrologist at King Fahd Medical City, and he's the associate executive director of academic studies, adjunct associate professor, College of Medicine at Al Faisal University. Please welcome with me Dr. Khalid.
Assalamu alaikum. Thank you, Dr. Haja, for your kind introduction and for the organizing committee. It's my pleasure to be here with you today. So, can you just see the slides? Okay. So here's my disclosures. I have none, and so I think you have heard about the pathophysiology of PNH and atypical aHUS, and you can see here that it's truly complex process that have genetic mutation, polymorphism, and autoantibodies. So it's not an easy thing that we can tackle, and we try to shed light about the advances in the treatment of this disease. So the current therapy options that we have so far is that we have supportive care, immunosuppressive, including steroid, the C5 inhibitors, blockade, and the plasma exchange. If you look at the supportive care and what we mean by that, we have the blood transfusion if someone have very low hemoglobin and symptomatic platelet transfusion, and we have to correct the electrolytes if there is hyperkalemia or other abnormalities, and if there is overload, we have to take care of that. Also stopping the nephrotoxic drugs, including ACE or ARB, if we have renal impairment that might need dialysis, and dialysis as indicated by the usual and standard indications. And we have the adequate nutrition because they might have some deficiencies if this is ongoing for a long time. If we look at the now, sorry, I think, yes, okay. So if we look at the historical options that we have and what we have about them as outcomes. So if we look at the plasma exchange and plasma infusion, unfortunately, we don't have any controlled trials that show that they have to be safe or effective in atypical aHUS. There is a serious complication and outcome in children, for example, around 55%, and adult around 15%, and almost 26% of all patients, they have experienced a major complication, including death, infections, and others. So this option is not a good one. Dialysis by itself, it's not a treatment, it's just a support and only focus about the renal, but it does not reduce the thrombosis and others. Kidney transplant, either liver or liver kidney transplant, unfortunately we don't have a good study about that, but we have some reports that it is associated with death and other serious morbidities. Antihypertensive and backed RBCs, they did not change the outcomes that much. So if you look, this is a summary table showing that the different immunosuppressive combined together either as a steroid or immunosuppressive like cyclo or rituximab plus plasma exchange in different CKD stages, the outcome is not good, and you can see the rate of relapses is high. So the literature or what we have as standard, it's not good enough by itself to reduce the morbidity and mortality of the disease. This is just one example for one study showing that the outcome for morbidity and mortality, despite using plasma exchange or plasma infusion therapy, that at 1 month and 6 months, you can see that patient who received the treatment, the dark green one, is similar to the patient who did not receive it or the placebo, and similar outcome. You can see there's no difference in both outcomes at 6 months. If you look at the complex, process of the complement pathway, because before we just focus on the complement pathway in certain diseases, but now we pay more attention and we try to invent more medication to block this pathway at different level. And if we focus here at C5 convertase, you can see here we have almost around 8 medication focusing in this pathway because we have believed that it will have an impact on the outcome in certain diseases like eculizumab, rafalizumab, and others. So what is eclizumab? It's a humanized monoclonal antibody that binds to complement protein C5 that blocking its cleavage. And if we look at the literature about eclizumab, we don't have that huge number of studies about it, but we have these main three trials that showed that it is effective in atypical aHUS, including adult and pediatric, and I will focus on one of them. Just this is to show the mechanism, how does it work. So as you see here, eclizumab binds and has high affinity to C5 complement, and the terminal complement C5b9 complex will be blocked, and the proximal function of the complement remain intact, so we don't have a problem with the main function of the complement pathway. This is a study about eclizumab and showing the outcome after 2 years, and you can see here that the TMA event-free status throughout the course. And if we look at what's the definition of TMA event-free status is for 12 consecutive weeks, no decrease in platelet more than 25%, no plasma exchange, and there is no new dialysis initiated. So the achieved outcome was 88% at 26 weeks. Also at 1 year and 2 years remained the same percentage of outcome. So it indicates that eclizumab is effective reaching the TMA-free status. How about, because as you know, the half-life of eclizumab based on 4 studies and the outcome, it was only almost 11 days, which is almost 2 weeks. This is the dosing. So it's not convenient for patient to come. So we want something that is long-term. So rafilizumab came on board, and it was engineered from the primary compound or from eclizumab and modified to be long-acting and give the same effect. And the difference between them that rafilizumab is based usually on the weight, so it can be 4 or 8 weeks interval, and usually we base it every 8 months, which is more convenient, and we want to make sure that it has the same outcome as eclizumab. So this is one of the studies that showed the efficacy. So you can see here that the design made that they looked at the safety and efficacy and the pharmacodynamic and pharmacokinetic of the study. So they gave loading dose and they changed it to maintenance dose based on the weight of the patient. And you can see here, this is the initial maintenance dose after the loading. Then they continue maintenance again, extension period up to 4 to 5 years. The main inclusion criteria, of course, they included adult. They looked at clinical evidence of TMA, thrombocytopenia, if there is hemolysis based on LDH, low hemoglobin, or if there is kidney injury. And they excluded someone if they have TMA for other causes like TTP. They excluded, for example, someone who has bone marrow transplant, pregnancy, if someone used immunosuppressive therapy, if someone have used prior complement inhibitors, or they have certain medication, or if there is a chronic rituximab use from this study. And the endpoint, the primary endpoint, they wanted to see the TMA or complete TMA response, which is normalization of platelet, normalization of LDH, and more than 25% improvement in serum creatinine. And the patient had to meet all the TMA response criteria in 2 separate assessments, more than 28 days. This is the secondary endpoint. They looked at the dialysis status, time to complete response, over time, change from baseline on these parameters, including quality of life. And they looked at the characteristic of pharmacodynamic and kinetics of the medication, and they looked at the safety part. Here, and this is the primary or the outcome for the lumped in one paragraph, and you can see here the improvement in the initial period, 26 week, and I will talk about them one by one. So if we look here, this is the hematological parameters, and we can see here that initially after the start, the hemoglobin or the platelet has improved and maintained over the period of time. And we can see this is a really significant outcome. And this is the LDH, which reflect the hemolysis, and you can see there is reduced in the amount of LDH produced here, and it was maintained after the 26 evaluation period. Hemoglobin was improved by 80%, and increase more than 2 or 20 based on the unit they used in this study. Again, it is also maintained in the 2 years period. GFR, I will just show it here. We can see here that the GFR improved by 68% in the patient by 26 weeks. And we can see here the baseline, almost 41 had eGFR in the category of stage 4 or 5, which has improved at 26 weeks up to 32, or it was improved. So this is a significant outcome. How about the dialysis requirement? Because it's one of the indication or the outcomes for those patients. So of those who were not undergoing dialysis initially, only 22% of the patients, they required dialysis at 26 weeks. And at the end of 2 years, only 20% they needed dialysis. If we look about stopping the dialysis, so of those who have dialysis at baseline, 56% of them, they were able to stop dialysis by 26 weeks, and 66% they were able to be off dialysis by the end of the 2 years. So it indicates again that there is improvement in eGFR. How about the quality of life? I'm not sure why it's not showing here, but again, there was an improvement in terms of quality of life, and it was around by 55%, so it's significant improvement. How about the pharmacodynamics? So the complete terminal C5 inhibition was immediate and sustained in for 2 years. And you can see here, this is the initial complement level, and you can see it was improved and sustained all the duration for 2 years. So how about the safety data? So it was comparable, it was safe. The main side effect was headache, diarrhea, maybe some cough in some patient. And there was no meningococcal, pneumococcus, or Haemophilus infections during the 2 years of follow-up. So the key messages for efficacy, so it is working, improve all the parameters, including hemoglobin, platelet, and serum creatinine, and the safety was no major concern about the cases. There was only 3 deaths that were reported, and these occurred in the first 26 weeks, so it's not significant. How about switching from patient? Because majority of patients are already on ocrelizumab. Is it safe and effective to switch to rafalizumab, or just we will keep it for the start from the beginning? So this is a real-world evidence, and this is a study. They looked at different parameters, including the medication, the quality of life, and others. And you can see here in this study, they include 32 patients. I'm not sure why the colors are not showing. So they looked at 32 patients who are on ocrelizumab. They did analysis of hematological and renal parameters almost like 3 months before switch, and they switched. They followed them 3 and 6 and 12 months. And this is the primary efficacy endpoint, looking at disease monitored by hematological parameters and the conserved kidney function. And they did subgroup analysis for renal status and time since diagnosis. So if we look at the outcome, there was no significant change in the hematological or renal outcome for people who were changed. And when they did the stratification about the time of initiation, so if you did the switch to rafalizumab less than 6 months from the time of initiation, those people did better. Both of them, they did good, but the people who have earlier switch, they did better in terms of outcome. You can see here the level of improvement if we compare it to this line. Same thing about the renal status. People who were switched earlier than 6 months, they had a better improvement in the serum creatinine in comparison to people who were switched after 6 months. So switching is also effective and working fine. Regarding also they included some patients who have a transplant. In this study, they have 10 patients who were previous had kidney transplant, 6 patients due to end-stage renal disease related to atypical aHUS. 4 patients has more than 1 transplant. So they did better, and also they looked at the genetics in that study. The result, again, regarding the adverse event were similar. It's just the upper respiratory tract infection 22%, headache and dizziness 22%, and also some diarrhea. It includes also one side effect of hospitalization for kidney biopsy, but it's not related to the disease itself. This is just a summary of the previous trial that I talked about. So the complete TMA response was achieved in 54% of patients, and 59 patients on dialysis at baseline came off dialysis by day 183. And this is another study show of a global registry showing the switching from eculizumab from eculizumab to rafilizumab, and we can see here that it has similar effect in terms of GFR, platelet, and others, and there was no need for new dialysis and comparable side effect and safety to eculizumab. Another trial that we talked about. So this is just a recommendation for pathway for initiation. This is from the European group, and also we have similar one that come from the Canadian group recommending how to start treating the patient who have in the immediate phase and the maintenance phase. And of course, after you start the treatment, you will assess if there is no pathological complement gene variant detected, and then you can discontinue the treatment if needed and monitor the disease. If someone has a pathogenic complement or gene variant detected, you will continue the treatment and you will monitor. There is still debate about how long you will continue this treatment. It's not sure yet. And this is just one study about the transplant. But we have some reports about the efficacy of eculizumab and rafilizumab at transplant. With that, I would like to conclude. Thank you so much. No, it's European guideline. Yes. No, we don't. I'm not aware about. From nephrology point of view, there is none. I'm not sure of hematology they have, but I'm not aware about.
I think this is a great opportunity if there is none. I think we should, since we do have this indication, to have a national guidelines for aHUS, I think, in my opinion, whether it is even for...
Yes, I agree. And it's better also to be combined between pediatric and adult, because we share the patient and they will have transition down the road from peds to adult. Yes. Dr. Mohammed, yes.
So in PNH, what we usually do, we actually see some hemolysis markers are improving. As Dr. Azza was saying in the first part of today's conference, he was saying that we try to save the cost. We try to space out doses longer than 2 weeks. But usually he would rely on improvement in the LDH, reticulocyte count, hemoglobin. For you, I know there are a lot that you would need to judge whether this patient can come off or not. Is there any other surrogate marker you would use personally if you want to give this patient like a trial free from eculizumab?
Yeah, actually, it's always a challenge when you have a rare disease and you don't have large volume and guidelines for that to monitor. So it is usually depends on individualized on the patient. So I would look at the clinical symptoms plus the parameters that you mentioned. Also look at the renal function. So if I have all of them had improved, I might give it a period of like giving holiday from the medication and monitor these labs. Exactly how frequent you should do it, there is no correct answer, because it's based on the expert opinion. What do you prefer? Okay, so and also it's different if the patient has a previous relapse or not. So you will judge from the time between the this relapse and not. Some of the recommendation says just observe for symptoms by the patient. You will do it monthly. Some people say we'll do every 2 months, and you will do it based on there's a new infection like upper respiratory tract infection. There's a new vaccination because these can be a trigger. So you can do analysis after that. Even the question, how soon after the infection you will do it? Because you will do it next day, maybe there is nothing. It will be triggered after a few days, so it's not an easy answer.
At your center, do you have readily accessibility to genetic testing for these cases? Because
Yes, we do.
I think, is it factor H tends to be the worst, and those are the ones that cannot come off inhibitors. So you have access to genetic testing.
We do. And I think our colleagues in pediatrics also have more experience because they have larger volume of patient. Yes. Yes, okay. Thanks. Thank you.
الحين تسمعوني؟ لا. طيب. check. yes. صح؟ الحين تسمعوني؟ yeah. طيب, thank you very much, Dr. Khalid, for this excellent presentation. Now, please welcome with me Dr. Abdelkarim Al-Anizi. Dr. Abdelkarim will be talking about leading the way strategies for optimizing aHUS outcome in clinical practice. Dr. Abdelkarim Al-Anizi is a consultant and pediatric neurologist. He is the chairman pediatric subspecialty in King Fahd Medical City in Riyadh. Please welcome with me Dr. Abdelkarim.
Assalamu alaikum. I'm not sure really, are you welcoming me at the end of the day? Everyone is really about to say, please give us rest, including myself, by the way. But I hope the presentation will make it just, as pleasant as we can.
So they always save the best for the last.
والله صدق أنا حاولت أقنع نفسي بالكلام هذا. طيب. البرزنتيشن موجود؟ Can go to the first one. Meanwhile, till we, if in the title it's being used for my presentation, we're just trying really to exchange our experience. And it was truly a good opportunity for me to hear from this morning, for our colleagues as a hematologist, working with a disease which is caused by complement. And I truly realized how difficult and how challenges they are facing, as we do also when it comes to the aHUS, because all related to complement disorder. The only thing I can see it as an advantage for patients with aHUS compared to those with BNH, that once you reach to diagnosis, because what is difficult really to reach to diagnosis, but once you reach to diagnosis, and you start the right medication, the right time, I think the outcome in our patients, especially those with aHUS, will be really, truly a good and excellent response. When it comes to BNH, even you can control part of the disease, but we cannot control the disease as a whole. The other difference that, in BNH, maybe it's really chronic in terms it's really part of other wide spectrum of the disease, while it is really, when it comes to aHUS, it is truly a systemic disease. But once you control it, the disease activity will be really well controlled, and the patient will be back to almost normal. So this is really the points we are going to discuss it together. And being also, we've been working in this disease almost more than around 15 years. The era before starting anti-C5 and the era after we start the anti-C5, I can tell you there is truly a complete change. The medication, the anti-complement medication has changed completely the outcome and the natural history of the disease. Also, I'll try my best in my presentation to reflect our own data, because really, we can really always learn and take lessons from others, but it's good also to look up to our community and try to see how much we can get out of it, including that when it comes to genetic, especially with Brazil, Dr. Amal, in pediatric or in aHUS in general, the genetic has a major role. Almost 70% of cases till now proven to have a genetic background compared to the other disease. When we started, we talked about 50%. Now we reached to around 70% of cases already identified the genetic cause for it. So this is just a diagram to see the complement-related disease. We are not really limiting ourselves to aHUS. No, you can see in this one, so when you talk the complement system as a driving cause or associated with this one. So the driving one, you can find it in the aHUS, C3G, and primary immune complex MPGN. Once you move to this direction, the involvement of the complement system in the pathogenesis of the disease will be less, but still it has a role. So still always we have to think about complement dysregulation to modify the outcome of most of the related diseases. Even IgA nephropathy, as you know, now they already approved anti-C3 in that one as one of the disease specific to management of the IgA nephropathy. I'm not going to talk about this one because our colleagues already illustrated in a very good way, so we are already familiar about this one. But it is just to tell you that our focus will be in the alternative pathway of the complement, and everything we are working really to know that this is one is associated with the aHUS disease, and it has to have a second hit. You have the genetic predisposition for the disease, but you need to have a second hit to manifest the disease. In nephrology, usually we talk about two things. When patients present with a picture, we call it team A, you need to differentiate. Are you dealing with hematological disease, TTP? So patient will be treated by our colleague hematologist, or it is related to us in nephrology that you are dealing with aHUS. If you have aHUS, again, you need to differentiate. Are you dealing with what's called before as typical, or still they call it typical aHUS, which is really, mainly related to the stick. It's related to the E. coli, it triggers the disease, or you can infection, or you can talk about what is really the atypical part of it. What is unique about our nation or our country, or even at the JCC level, what we found, in the textbook you will find aHUS, 90% of it caused by the typical, which is really related to the bacterial infection with E. coli. Only 10% related to aHUS, which is the atypical. But what we found in our community, it is completely the opposite. It's hardly during our practicing to find typical aHUS, while we start to see more cases of the atypical one. This is one just peculiar about our community. This is the triad which we need to have it to talk about aHUS. You need to have the thrombocytopenia, you need to have mechanical hemolytic anemia, and acute kidney injury. Is this triad always present? Patient does not read textbook. So this is true, and this is part of the challenge. When we talk about aHUS, as all we know that it is one of the ultra-rare disease, percentage or incidence around 0.5 to 1 per million per population. And, at least 50% of patients with aHUS have underlying inherited complement. But what we found really in our study local, that no. And there is something I'll talk about. It's related to the consanguinity rate in our community. It's really, we reach in our study up to 60%. And one point, sorry, about this is non-complement inherited abnormalities. We also have cases related to other system, not complement. Either DGKA, which is related to the thrombotic system, or other genes, I will talk about it later on, which we discovered and we already reported that it can give you clinical aHUS while the underlying disease is different. So that's what we need to have: clinical manifestations, laboratory investigation, and genetic testing. Genetic, it's not really mandatory to initiate medication, no, because medication has to be started within 48 hours, to save patients and to save the kidney. This is our own study, by the way. This is Saudi Arabia clinical data. So as you can see, patients usually when they present, this is what usually they present: hematuria 48%, hypertension. And look at hypertension. By the way, we found our patients, the only clue to reach the diagnosis was only hypertension. And I will present one case to you. Proteinuria, almost 58%. it's part of the acute kidney injury, and body swelling also very high, more than 75%. This is the manifestation because it's systemic disease. Sometimes they can really misleading by presentation. So GI symptoms really one of the dominant one, as you can see, vomiting, 70%, diarrhea also. They may have, just URTI as a trigger usually. They may have other, manifestation which reflects even CNS. They can present with seizure. They can come with different, conscious level can be affected, and sometimes just skin manifestation. When we come to evaluate patients, usually we try to categorize our approach in different way. First one, just to identify the presence of TMA, because this is the main thing. We need to know that we are dealing with TMA. So this is the list of investigation which we need to do. I don't want to go over it quickly, but you can look at it. The second category, if I will take the degree of organ injury. So as we know, it's a systemic disease, it's multi-system involvement, then we can do those investigations to check at the general exam, renal function, liver enzyme for liver function. We talk about pancreatitis, also it can be one of the complications. We can look at even cardiac, because some of our patients, they presented to us with cardiac disease, like you can say carditis, if you could use this one. Troponin will be so high. The third category of investigation we try to do it according to the suspicion as underlying cause. You can see this one. Either Shiga toxin, when you talk about the typical Adams 13, as you know, in hematology, you talk about TTB as a cause. Or we can go further to think about it, like, we had cases who have HN1 and COVID-19 during the pandemic era. Homocysteine and vitamin B12 blood levels, especially when we have younger age group pediatric. We talk about neonatal presented. We had one case who presented at 1 week of life as clinical aHUS. Vitamin B12, it's really very helpful to tell you because this is one of the secondary cause for the aHUS. And let me just focus on one fact. aHUS, it is a clinical diagnosis. It has nothing to do based on the genetic or it is just to confirm. But once you have a clinical diagnosis of aHUS, it is aHUS, and you need to see is it really primary or secondary. Okay, in case of renal biopsy, is it really mandatory? No. But in certain situations, we can do it. Either at the beginning, we're not sure really what we are dealing with, so we need to know to do it. Or sometimes to see, is it really beneficial to continue giving the anti-C5 for this patient, or to see the degree of the damage to happen to the kidney. About genetic study, I can tell you all patients, once you suspect this one and you prove it's really most likely primary, you have to go for genetic study, but there is special indication for this one, especially when you have patients who have a relapse aHUS or familial history, or you have patients who have aHUS for pregnancy, postpartum aHUS, de novo post-transplant aHUS, and genetic screening before doing the transplant to decide about it, because some patients, they will come to you when you suspect, as the cause for it, aHUS, you need to do it to know that you prepare patient by giving him anti-C5. By the way, genetic study, it's not forward when you say genetic study. Dr. Amal, she can tell us better than me, but in general, sometimes you will have something called unknown significance. So is it related to the disease? We don't know. So even if it's positive, doesn't mean it will always be pathogenic for the disease. Second to this one, there is the limitation. Because as I told you, around 30% of patients or 40, it's negative. But it's truly negative. How it comes when you have more than one member in the family that are really positive. And again, the time it takes. Till now, the best we could have it 3 weeks or 4 weeks to have the result. But once you have result, you need to analyze the result to be sure it is related to, can explain the disease you have, plus the cost. Again, this is our study. And this is, as you can see, based on the literature, factor H is the main cause, But what we found in our community that the combined, I'm not sure, it's not clear here, but the combined mutation, it's 22%. It's a combined. That means you have more than one gene mutation cause the disease. Factor H-related protein, and this is peculiar. Dr. Khalid talked about steroids. Factor H-related protein usually associated with anti-factor H, which make even the response to the treatment make it really less likely. If you just don't consider it, you may give patient the right medication, but the response won't be the optimal or as you expected. What we have really peculiar, maybe ممكن نصلح زميلنا الدكتور مثلا, what is really gene really more affected? Factor H, it is known, it is one of the worst in terms of the clinical and in terms of really you stop the medication, what will happen. But in our community, we found C3, and we have a good number of patients who have C3 mutation. And to be honest, we try one time to discontinue patient. Listen, shortly he developed, a relapse, and it was very bad relapse. Thanks God that really when we start the medication, resume it immediately, everything back to normal. Yeah, there's something mutation, but not related to complement. This is one I told you before, like Wilms tumor 1 mutation. This is really specific to certain syndrome in pediatric, and it's associated. We have 4 cases, we reported already published, this one. And DGKA mutation, we have also a good number of family with DGKA mutation. What is peculiar about DGKA, they don't respond to anti-C5. Usually, whatever you will do, they will continue to have proteinuria, chronic kidney disease, hypertension, and unfortunate. All intervention has been tried, even globally, proved nothing to stop the progression to the chronic kidney disease. This is really one of the causes of nephrotic in pediatric, and we have also one case who will also be presented in the IBNA next month, inshallah. Dr. Khalid talked about, how should we manage those patients. I'm not going to go over it to this one, but one talk maybe when it comes to the renal hepatic, because, there's no curative measures you can do it except this one, the renal hepatic, because you will just give him, now when you give the liver, most of the complement inhibitory factor produced by the liver. So if you give him transplant liver, this is the only curative way of the disease. But when it comes, is it really as a whole something you can take it? No, because there is a lot of risk. You talk about 2 organs, transplant with the complication and consequences of transplant immune suppression. Okay, again, I'm not going to talk about this one because it has been covered well by our colleagues. This is the study which showed really when do you expect the response? Because we as a physician, we'd like to know, are we doing the right thing for our patient or no? Hematological response and clinical response, mainly we'll talk about also renal response. Clinical including, hypertension, how patient is doing. Hematological is the first to see. Usually with one week, you can normalize platelet count. When it comes to the renal, usually, most of the cases you can see in this one, it's really, this is the blue color, that's been 1 week, okay? This is the time, less than 1 week. Usually you can reach up to almost, you can say 70%, they can attain their normal renal function, improvement in renal function in the first week. But usually we see it within 10 days to 2 weeks to have back to normal. But doesn't mean that all patients will have, but most of them, as you can see, based on the percentage. When you ask about the protocol, and as Dr. Hajar, we established our own protocol for managing this patient. I think I shared it with you before. We are really updating this one also. We hope, inshallah, we can work as a group, including both pediatric and adult, through the Saudi Society of Nephrology to establish our own clinical program. I know there is activity or some efforts done at, Saudi Society of Nephrology at a global level to establish also aHUS management group, and we are really still adopting, what is going. But as you can see, our data, it really reflects something different from others. Okay, this is the journey quickly. I will just go over it quickly. We started, when it comes, 2007, we started managing our patient, but what we have that time, Aussie plasma therapy and plasma exchange, okay? And that outcome I'll show to you. But when it came 2014, we started our first patient to 2014, and we managed that time around 24 patients, who received the ocrelizumab, which I can tell you it was really a turning point, completely turning point in the outcome of the disease. And we also, so we have the courage to discontinue the medication based on criteria I'll talk about it, because this is one of the most serious decisions you have to take it when you say I will discontinue the medication. You know, always patients at risk, so you have to be highly selective with certain criteria with the close monitoring of those patients. And we published really our data about the discontinuation, because we publish it but at the GCC level. I will show it to you inshallah. And we switch our patient to in 22 to from ocrelizumab to rafalizumab. We'll show also our result in that one. So what is the strategy for optimizing outcomes? The strategy really depends, first of all, in early recognition and diagnosis. Early recognition, it needs a lot of efforts to reach to the people who will see patient first. I'm talking about internists, pediatrician, primary health care, before you talk about the nephrologist, because those who will refer the case for the nephrologist. And we initiated already a program, you know, we talked, Dr. Haj and Dr. Ahmed before, and talk about part of the, how can we centralize this management. So first part of the centralization to start outreach program, which is already launched, and we had it in many areas, many regions in our country. Second, use of complement inhibitors. That means we have to have access to the medication. If you don't have access to medication, how can you? Third, which is the most important, to have a multidisciplinary team. You cannot work it as nephrologist alone, for sure. Okay, this is the multidisciplinary approach, complement-related kidney disease. We already established this team in our KFMC, and we have all those people who are really part of it. And this is the objective: early diagnosis, rapid diagnostic pathway, advanced genetic testing, comprehensive complement function assay, profile C5, and communication with the family through the coordinator. Nothing without challenges. It's not easy journey. Okay, so some part of the challenges related, some of part of the challenges related to the disease itself. You know, as I talked about it earlier, till now, there is no universally accepted diagnostic criteria for aHUS. So aHUS is diagnosed by exclusion. You have to exclude a lot of, you know, causes to come to that one. Second, the similarity in the presentation can make difficult to distinguish aHUS from the typical aHUS or TTP. And you have to have high index of suspicion, okay? Infection may trigger primary aHUS, as recently illustrated by COVID-19, and we have almost 2 cases of this one. And therapy must be initiated early for TTP and aHUS to prevent end organ damage, and the recommendation to be within 48 hours. Another challenge that it's not always that triad you can have it to diagnose, because yes, if you have thrombocytopenia, mechanical anemia, and you have acute kidney injury, you will think about, you know, aHUS. But what happens if you don't have all? This is really the challenge. Severe hypertension without a clear reason can be one of the manifestations of aHUS. I'll show you one case to tell you about this one. Okay, breaking barriers success stories in aHUS. This is the first case which has already published this one. A complete renal recovery in atypical aHUS after 9 months of dialysis. Just imagine, you have patient already in dialysis for 9 months. Once you know about the diagnosis, you could reach to it, and you initiate medication, you can bring patient back to normal. I don't want to make the story long for you, I'll make it short. You know, this patient who presented to us with the typical, I mean, he was presented typically as aHUS, you know. Sorry, no, this is not the one. No, they presented atypical. 18-month-old boy presented with AKI anemia and normal platelet count. See, can you think about aHUS? Maybe you could not think about it that time. Diagnosed initially as glomerulonephritis by clinical manifestation and renal biopsy. If biopsy did not show TMA, corticosteroid pulse therapy, plasmapheresis were ineffective in resolving the need for dialysis, and hypertension was refractory to polytherapy. He was in almost 5 medications, antihypertensive. Diagnosis of partial aHUS normal platelet was suggested by low level of complement C3, because this patient, when we send, you know, SA, we thought about, we just suspect based on hypertension. I told you sometimes hypertension alone can give you a hint. We initiated investigation for aHUS, and it came to us that patient have some deficiency in factor factor B and factor I, and also complement C3. And when we did the genetic study, it was that time used next generation sequencing, indicate homozygous pathogenic mutation in factor I, heterozygous variant in C3 and C factor B. So 3 mutations in one patient, okay? Yet he was not presented typically. So what happened after that? Therapy with eculizumab initiated only after 5 months. And this will message tell you, don't give up when you treat those patients. So after 5 months of dialysis was associated with rapid increase in urine output, control hypertension, and slow but complete renal recovery. So patient was in dialysis. He already total 9 months, but 5 months while he was in eculizumab. What happened at the end? It was something amazing. We reported. Currently, I still see him in my clinic. He's completely normal. He is no medication, normal renal function, growing, and he's happy with his family. This is the second case of success. If challenges, we have healing after dialysis and stroke, restoring kidney function and CNS health. So it's not just the renal. We received this patient from the local hospital in the south. Okay, she's 4 years old female, presented to the local hospital with bloody diarrhea, vomiting, and low-grade fever. She developed seizure, the breast level of consciousness, AKI. She was started there in peritoneal dialysis. And the most likely diagnosis at that time was what? TTB, because in neurology, because we have some sort of thought, if you have AKI with neurology more, think about TTB. So patient was referred to us, and that time Glasgow Coma scale was only 7. She was hypertonic, hyperreflexic, quadriparesis, difficult swallowing. She was on NGT, in oxygen, but she was normotensive, oliguric in BD. So what do you expect the outcome to be with this one? She's already, you can see, handicapped. She had severe neurological manifestation, as you can see, stroke, difficulty in swallowing, difficulty in speech, quadriparesis. After 3 years of eculizumab, I'm telling you, we started eculizumab, but I'll tell you what happened after 3 years of eculizumab. This patient is hematological remission, renal function normal. I saw her last week in my clinic. Recovery of conscious level, improvement in walking, normal swallowing, hearing, vision, no seizure, she is studying. MashaAllah, she's really performing well in school. This is the point. Once you reach the diagnosis and you share the right medication, you will get excellent outcome. So discontinuation, is it possible? This is the question every one of us will ask. Why? We should ask this question. First of all, we know, does the patient need it all? We know he has genetic predisposition, but does it need it all? We have to say yes or no. Second, can we offer this medication in all situations? So we have to establish some sort of protocol to support this one. Okay. This is really our criteria for discontinuation according in our program. You can see it. First of all, you have to have no clinical evidence of ongoing thrombosis and thrombotic microangiopathy. That means you have to have platelet more than 150, and to have also negative genetic testing. This is very important, by the way. Okay? Or to have both positive genetic but not related to complement. That means you talk about non-complement mutation like the GK. The only exception we talk about it when it comes to complement the CD46 or what's called MCB. This is truly considered some sort of, I don't want to say benign, but it's really, even these frequent relapses, we had patient who was not eligible for medication. He had more than 15 relapses, can you imagine? But still he maintained renal function. So this will give some sort of courage to, yeah, we can be selective when you talk about discontinuation. And also, renal function has to be normal, no active trigger, no organ transplantation for aHUS, because this is another category. A patient already started, transplanted, and he's in anti-C5, you have to be careful about it. And patient adherent to follow-up. This is very important. That means you have access monitoring system, and we allow patient to decide also if they will go with that trial or no. Okay, we did our study, by the way, multi-center. We include, as you can see, 12 centers in 5 countries. And we could manage really 28 patients with clinical diagnosis of aHUS who had discontinued eculizumab during a median follow-up period of 2 years after discontinuation. Only 8 patients, that's been around 28%, they have the relapse. The risk factor for recurrence was positive genetic mutation. And see what was the p-value? So significant. So we learn from this one, and this is not limited to Saudi Arabia. It was really GCC, as you can see, 5 countries contribute for the study, that there is a chance, but you have to be so careful about it. And we published that one. Now the switching, our experience switching, are you still okay, by the way? Yes. Great. Switching from eculizumab to rafalizumab. You know, as Dr. Khalid talked about it nicely, I don't want to repeat this one, but I can tell you about our own experience in this one. This is our patient who has been, you know, shifted from eculizumab to rafalizumab. As you can see, they have all, the only exception this one, the rest, they have very bad combined, or those C3 I told you is really very bad, you know, mutation, yet all of them, they are in remission. Once we saw, you can safely shift patient from eculizumab to rafalizumab you can maintain a good outcome. Okay. So atypical aHUS can be presented with atypical presentation. This is what I told you. Sometimes you can have patient, you don't think about, you know, aHUS as a cause, you know, cause for it, you will present with like this. You know, already published this one, association of atypical hemolytic uremic syndrome with Wilms tumor, gene mutation, a case series. We publish it and we talk about this one, 4 cases with this gene mutation. They present clinical aHUS. The other presentation also already, this is already, we presented in our last Saudi Society of Nephrology, a new presentation of atypical hemolytic syndrome, and we talk about, you know, patient who has, as I told you before, with other gene, is not related to complement, but clinically presented as aHUS. And this is the last one which we also published about glucose 6-phosphate deficiency. Hematology, they know about it, and pediatrician, you know, the cause has nothing to do with but they can also present with, you know, aHUS clinically. They don't need to have, you know, anti-C5 once you know the diagnosis. Okay, the outcome, this is our study about, you know, the outcome, and this has been published in 2019. Currently now we try to validate this study by having, you know, a multi-center study. It's really running now, including, I will show it to you. By the way, regarding this one, maybe Dr. Khalid talk about it or other. You know, if you compare anti-C5 with the usual historical management of this one, there's no way to compare them. Look at this one. Those patients who have complement mutation, and this one, no complement mutation. The green one is those who have a remission, and red, no remission. And as you can see, those patients who have, you know, if you compare, when you start C5 inhibition to plasma therapy, no way to compare. There's no way. So this proves to us that, you know, once you start anti-C5 in the right time, no one can recommend alternative therapy like, you know, plasma therapy, plasma exchange, unless for logistic reason you cannot afford it. Side effect, you know, this is our own data also. What we found really, we have no incidence of meningitis. And despite we treated till now around 45 patients, we don't have, alhamdulillah, any single case of meningitis. The only thing we have is really acidosis, hypertension, and you can see none most of the cases. Even acidosis, we don't know, is it related to the medication or related to the disease itself? Because during the acute kidney injury, this patient he may develop tubulopathy, we call it. Okay, this is the current, you know, study we are conducting, which is the clinical presentation and outcome among patients with atypical hemolytic syndrome, a multi-center retrospective study in Arabian Gulf countries. Honestly, I contact even Asian countries to contribute in this one. So we have, you know, 18 centers who is going to contribute, already starting contributing in this one. I hope we can validate 2 things. One of them really the genetic background, you know, because you have more cases, there's more advancement in the genetic testing and identify more genes. And also we need to validate, the response to refleximab, because we will focus more on this one, because this is the time, the initial study, we did it before refleximab, and this is really done while patients in refleximab. This is the protocol, you talk about it. I think we mentioned before. But the take-home message from my presentation that aHUS is systemic disease, not limited to kidneys. aHUS is a clinical diagnosis and needs high index of suspicion. To date, there is no universal accepted criteria for diagnosis. Early recognition and treatment is crucial in outcome, and treatment with C5 inhibitor change the outcome of aHUS. And this is a new direction. This is really what we talked to Dr. Hajar, Dr. Ahmed, and I really would like to thank them because they are really always positive and very supportive when it comes, how can we look at a national level? At a national level. So this is really the new direction now, to create a national aHUS Center of Excellence to standardize and diagnosis and treatment, implement genetic screening and rapid diagnostic pathway to improve early detection, develop a national aHUS registry, which Dr. Hajar, I think she talked about it, to track outcome and drive research, ensure equal access to advanced treatment through policy and economic support, foster research and innovation in AI-driven diagnostic and novel therapies, and increase training for healthcare provider and raise public awareness. The last one, we already started in that one. I hope we can include public also in this one. And AI, I think there was some sort of suggestion. We've been contacted by one of our colleagues. He's really from IT, from Medina, and he's interested nowadays to talk about it, to conduct some sort of study about this one. And also, I think there was also initiative from our colleagues in AstraZeneca also to support some sort of, protocol, project like this one. I hope we can have it, inshallah, soon, bidnillah. By this, I would like to thank you, and thank you to bear with me during this last talk. Thank you. Sami.
When it comes to AI or early prediction for those patients, rather if يعني زي اللي احنا شفنا انه في there is for diagnosing of this disease, it's by exclusion.
You are right.
Is there anything coming that would really help in early diagnosis or prediction when it comes to those?
I think yes, the answer truly, especially with AI nowadays. By the way, I'm sure every one of us now has experience with either ChatGPT or the DeepSeek. Myself, I would like not to make it, it's a secret for, I could have in the back door to subscribe to ChatGPT a long time ago, okay, by using international number. So I have good experience with it, and also DeepSeek, which started just less than 1 week. I think this is really just the start, especially the DeepSeek, if it's really will allowed by others not to have cyber attack to it. Yeah. I think we can, but I think we can make it as project by support of our colleague in the pharmaceutical company. Yes. We are ready for it. The data itself, we have it. It will make easy, because what's going on? You need a lot of, how can I say, a lot of, thinking to reach diagnosis. So AI, he can help you in that one. He will make it easy for you. I think this is my response to you.
One last comment. أنا شفت your team بس ما شفت pharmacist ولا clinical pharmacist.
لا معنا والله. الدكتورة كاثية يمكن تعرفوها. يمكن آسف الخطأ مني ما كتبتهم. لكم حق. لا هم ناس.
الله يعافيك. شكرا. Thank you.
شكرا لك.
Thank you for the presentation. Just you have a question about some unusual scenarios. I want to take your insight and recommendation. I saw 2 cases actually. One of them was 3 weeks ago. You mentioned that there is some genetic predisposition first and then the second hit. I saw 2 patients like 3 weeks ago. He showed me the genetic reports. He doesn't have any manifestation of aHUS, no clinical manifestation at all, and he has positive gene for susceptibility for aHUS. What do you recommend to do for these patients regarding follow-ups, and how do you make sure if he drops at any hospital that they take it in consideration?
Excellent.
It's difficult to rely on the family alone to inform the physician.
By the way, Ms. Fatma, I would like you to allow Dr. Ahmed to respond. And I forget to thank also, the organizing committee and also Ms. Fatma and others who organized this one. Lakin, I think I would like to hear from Dr. Amal, لأنه we as a nephrologist, we treat when we have disease. But the question now when we do, and this is really, I really promised you will give me more time to talk about it. We proposed for the Ministry of Health to have a genetic screening in certain high-risk group, we call it. And it's already submitted to MOH authority to talk about it. The question about, how far we can think about if it's positive, I would like to hear from Dr. Amal.
Doctor, this patient who had positive, was it pathogenic or only susceptibility?
Pathogenic,
Pathogen.
one,
Yeah.
CD46.
And
He doesn't have any manifestation. And it's in the report, they ensured in the symptom report
yeah.
that the patient is susceptible for
Susceptible. So it is the one with susceptibility, not the one with conformity.
It doesn't present of aHUS.
Yeah.
It's just susceptible to have it.
And another question: is any then family history of one or anybody is there? For me, if I would like to approach those, I would bring the family member. I would like to test them, especially those who are elder age. I want to see if any one of them he had the same homozygous, because it's homozygous, isn't it? And they didn't have it, so maybe this is some of the disease that we say the variable presentation, or the penetrance is not there and the autosomal recessive, but the variable presentation that some will have lower or late onset, or some susceptible later, because aHUS, the susceptibility which come different than the other genetic monogenic that like sickle cell. They have it, they should have it. Some of the aHUS, it's susceptible, they have it. So, because different. But
He's not prone to have it like at any time.
Let me just explain this one from my, when it comes to your second part of the question, I think it's really the answer. You ask and you answer yourself. I think, yes, those who have index case, as Dr. Rashi asked, if they have index case, those who have index case, no. Family has to have genetic counseling and to give them the awareness themselves. And if you have a contact with the local, physician who start treating them, or family physician, you have to also meet them. Because once those patients have any clue, any manifestation, you have to think immediately about the aHUS, not anything else.
Okay, now it is my pleasure, great pleasure, to introduce Dr. Hajar. Dr. Hajar is advisor to the Assistant Deputy Minister of Therapeutic Supportive Service. She is Director of Drug